Hi, John. How are you?
Oh, is this Wan?
Yes. Hi.
Hey,
Good to-
how's it going? Let me get my camera set up here.
Hey, good to see you again, sir.
Yeah, it's nice to be seen. Let me take it off the spotlight. Is Kate coming?
Yeah, she knows she's coming. Yes.
Okay. I think Warlick's is in the OR, so
Okay.
he's going to try to come. But you know how these things work.
Yes. So if you need my help, just shout.
Well, if well, Kate is moderating, so I'll just turn it over to
Yeah. Yeah.
her. So
Yes. Yes.
I basically, unless you want to be introduced, you want to be introduced?
No, it's fine. I'm okay.
Okay. Okay.
Keep a low profile. It's good.
Yeah, well, I always ask people. I don't want to,
Mm.
and draw attention if they don't want attention drawn to them. So, um, yeah, we've been having a lot of webcasts.
Yes,
They
you've been
all,
very busy.
yeah, yeah. Well, I'm glad. I'm glad there's increasing demand. Um, there's another neurosurgical. Good morning, Kate.
Hey, how are you?
How you
Hey,
doing?
Kate.
Yeah, good.
Hey.
Hey.
Hello,
Thank you.
hello, neurosurgical residents.
Hi there. Hello. Good evening.
Good evening. Good evening.
There are a bunch of them
It's
going together.
early in Miami. It's 7 o'clock.
Have you a drink as usual?
You.
So how many National Neuroscience Institute has a residency program in neurosurgery?
Yes, we have actually. We
And how
take
many?
about
Okay.
we take about two a year. I mean, there's a national program for the whole of Singapore. About
Oh,
two a
okay.
year.
Oh, okay.
So any one time there are about 12,
Okay.
12 to 14 depends. Some years we have taken more, but some years it's decided by the Singapore government. So we don't have a say of how many we want. They
Oh,
say
okay.
Mm.
Okay. And most of the residents are here from the residency program.
yes, actually a lot. There are like about 4 or 5 of them grouped together in one of the conference rooms where they'll be doing part of the
Okay.
webinar. Yeah,
Okay.
some of them are separately on their own, I think. Yeah.
Okay. Very good. Okay, I'll be back in a few minutes. I got to do
Sure.
some
You take care.
administrative stuff.
Yes. Yeah. Okay. So we unfortunately, there's also some clash on with what Basan is doing.
Yeah. Yeah, the WFNS Young Neurosurgeons.
Unfortunately, I don't know how the dates got clashed. We actually had fixed this for a very long time ago already. Never mind. We'll endeavor to have better timing. So, any of your residents interested?
Yeah, they're keen to do it as well. So we just asked one of the guys to put together think about some topics today.
Yes, and I think they can contact Jashu, who's doing it for us, and then we can combine. We're thinking maybe one session a month in the coming few months.
Yeah.
Mix of residents from different parts of Asian centers.
Yep. Yep. What is Warlock introducing?
No, she's not. She's operating today.
Okay.
I think she's in the OR. So apparently, John said he will just introduce you, and then we'll just get things going.
Okay. Yes, well, I've upset Basant.
Yeah, I don't know how we can. I guess we have to share dates more openly. But sometimes I think these things are because they're done on one side, we're done on the other side. It's like
No. You haven't been reading the AASNS Directorate WhatsApp then.
well, Oh, no, I think you just call him sir. I mean, that was what he was.
No, his emails, his invitations always go out to respected sir, to everyone. I pointed out that not everyone is sir. He told me I was too touchy.
uh, someone's.
Wan, do you want me to make you co-host? That means you can let people in.
Okay, I can help you with that. Yes.
Yeah, let me see if I can transfer you that privilege.
Thank you.
Yeah. So if you can see people waiting, you can just
Yes.
admit them. Sometimes I get distracted.
Yeah. No, I can help you do that. Not a problem at all. Pleasure.
Oh, good. I'm glad Vlad's here. We had a neurosurgeon to be from Romania that wants to help host events, etc.
Okay.
Vlad, are you there?
Good afternoon. Yeah, I'm here. Nice.
Yeah, I was just, you're being introduced kind of like suddenly.
I've listened it. Yeah.
Yeah, I was just telling the Wan is a neurosurgeon from National Neuroscience Institute. He basically organized this, and I just mentioned that I possibly have a new recruit named Vlad from Romania, and here you are.
Thank you very much for the introduction.
Welcome. Good to see you. Hello, Vlad.
As well. Thank you very much. It's an opportunity for me to participate at such webinars, such grand webinars.
Great.
So
well, you're gonna hopefully try to help me run them. So just stay in the background and watch and stuff.
Yeah.
And I'll probably make comments to you during the telecast. Warlick's got tied up in the OR, which is a common thing, as everyone knows. So we start in 4 minutes. Yeah, I'm not too rigid about starting on time. If it happens, it happens. Sometimes there's little technical delays. And one thing I'm learning is that if something goes wrong, just wait. Usually it gets fixed itself, or you ask the person to reboot.
Yes.
That's the extent, Wayne, of my technical knowledge. Reboot.
But you know when to ask people to reboot. That's the most important thing.
Oh yeah, that does help. But so how are things with COVID in Singapore? Is it things here are getting closed up again? They were opening up, but now in Florida, I think most of the United States is closing up again.
Oh, yeah, sad to hear. No, we're okay. Actually, we haven't had any community cases in the last 3-4 days. There are some small cases that imported, but they all quarantined before they're tested. So they can't get out of the hotel where they are until the 14 days and they're negative, then they get out. So pretty under control, but it means the country is shut down. Basically, very few people can come in. Virtually, many of us can't travel out. So we are kind of stuck.
Well, it was kind of good news about those 2 vaccines,
Yes.
and that Fauci, the guy that seems to have a handle on most of it, he said he was amazed at the success rate, or 95%. He was amazed. He expected like 50 to 70%, but 95%. One of the companies, vaccine companies.
Yes.
So that was good news. Yeah. So there is hope. Welcome everybody. We start in a couple minutes. All the speakers are here, and everyone knows how to screen share. Kate, you're a veteran, so you've done lots of these, right?
Yeah. I just wish they were in the middle of my day.
Really? That's right. It's what time is it there?
11 p.m.
Oh, p.m. That's the middle of your day. Oh, I didn't realize that. Okay. Okay. Now, Royal Melbourne Hospital is in Melbourne, right?
Yeah, correct.
Okay. Okay. I didn't want to say Royal Melbourne Hospital in Sydney.
No, it's actually Melbourne.
Okay. That's good. I just let a few people in here. And we'll be starting. Just let me let these last few people in. Everyone's coming at the last minute. Okay, Kate. 10, 9, 8, 7, 6, 5, 4. Oh, let me get off the spotlight. Sometimes I get on the damn spotlight. No, okay, it's straight. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. Dr. John Bennett for Neurosurgical TV. We have the pleasure of hosting a neurosurgical webcast hosted by Kate Drummond. We'll let her run the show. Okay, Kate.
Hi. Good morning to you, but good evening to me, and somewhere in the middle for the rest of our participants. Welcome to Neurosurgical Boot Camp, coming from the residents of the National Neuroscience Institute in Singapore. I'm Kate Drummond. I'm a neurosurgeon in Melbourne. We're going to have 3 wonderful presentations tonight. There'll be a short presentation basically on topics of interest to junior residents and anyone interested in joining neurosurgery training. Each of the Singaporean residents who are presenting also have a mentor to help out if they get any tricky questions. Now, John, are we putting the questions in the Q&A or in the chat? Where are the questions going?
I think the chat would probably be the best spot.
Okay, great. So if you do have any questions, then put them in the chat. But otherwise, I will introduce our first speaker, who's Felicia Chua. And Felicia is speaking about principles of neurosurgical positioning.
Hi, everyone. Okay, let me just. Can you all hear me?
Yes.
Okay, great. Okay, is the presentation shared on the screen?
Correct. Yep, it's good.
Yes.
Okay. So, hi everyone. I think I'll just dive straight into it. I'm Felicia, one of the neurosurgical residents at NNI Singapore, and I'll be talking about cranial positioning in neurosurgery. Basics that every neurosurgical resident needs to know, and my mentor is Dr. Carlos Rames. So going straight into it, the overview of what I'll be discussing today is essentially principles of ideal positioning, procedure and fixation methods of the surgery, and also I'll be discussing the common positions that we use in our everyday practice, the supine straight, supine head rotation, lateral, prone straight and 3/4, also known as park bench approach. So in terms of principles of ideal positioning, we would want to essentially aim of surgical resection really is to use the most direct approach possible to resect the lesion. And firstly, by doing that, we will need to get the lesion at or as close to the surface as possible. And one of the ways to do it is really to identify surface palpable landmarks that we can identify, position a patient appropriately, and intraoperatively also to identify craniometric or osteometric landmarks to help guide a lesional resection. The second point is, of course, we want to minimize brain retraction. And with that, we would want to use the help of gravity to pull away or shift dependent lobes away from our operative field. On a third note, which is a more practical note, is really to consider the ergonomics of the surgeon and the assistant during the actual surgery. So whether this operation is done sitting or standing, the microscope that you use, is it face to face or left to right? All these are considerations that you have to think about before actually putting a patient on table. And fourthly is to provide a clear operative field. What I mean by that is really to prevent unnecessary bleeding in terms of venous buildup, venous pooling. I'll elaborate more on this in my presentation. So the first point about landmarks, when we talk about landmarks, really, there are many surface landmarks that we can identify on the skull, obviously. One of the main ones I want to zone in on is the Taylor-Hockner lines, and the main one being that of the Nasion-Inian line. So this imaginary arc or line is what we mark out anteriorly from the nasion, which is a depression found between the eyes. It's the most anterior point of your frontal nasal suture, and you join it at the mid-sagittal cut, really forming an arc to the posterior point of the inion, and that's the tip of the external occipital protuberance. What this line gives out, or gives for you, is essentially avenues, or rather a method to eventually measure your Sylvian fissure as well as your central sulcus. So,
Lisa, do you have some other people in your room?
yeah, yes. Is there a lot of interference?
There's a lot of background noise. Yeah.
Yeah, I'm sorry. I cleared it up, I think.
Okay.
Is it better now?
If there's anyone
Yeah, I
else
think
in
it's
the
okay
room,
now.
yeah.
Okay, sorry. Just shout out if you can't hear me. I'll try and
I
read.
think it might be you shuffling your paper. Even we can hear.
Okay.
All right, keep going.
Okay, so back to the Nasion-Inian line. Basically, it's divided into 4 parts, and the Sylvian fissure really is a line drawn from 3/4 point posterior of the NI line down to the lateral canctus, and that forms your Sylvian fissure. The second point that we want to draw, that I want to focus on, is really to identify the central sulcus, and this is a 0.2 cm behind the midline or the midpoint of this NI line, and is drawn to an imaginary 0.5 cm above your external auditory meatus. So that marks out the central sulcus, which really points to the differentiation between how you identify your motor strip and your sensory strip. And that's important, especially when you want to identify lesions during the surgery. Other things we want to think about is coronal suture. So about 4 to 5 cm behind this line also is a point that you can identify the motor strip as well. The other landmark that found inferior to the lambdoid, and this really demarcates where your occipital pole is. It's also good for identifying points. So all these are just a guide to help you in your surface landmarks to really localize a lesion when you're trying to do an operation. You would need to identify it and then pair it with your neural navigation to see how accurate you are. Because firstly, not everywhere has neural navigation, and secondly, if it fails intra-op, you still need to be able to identify the lesion regardless. Okay. Other landmarks that are also important, this is just really purely for general when you're feeling a patient on table, is to find out if you have a lesion centered at the anterior fossa, such as a cribriform base meningioma, where you want to find the floor or the skull base of the anterior fossa. That would be at the roof of the orbits. The middle fossa would be your zygoma that you can identify. Infratentorial would be a line from the zygoma backwards to the inion. I'll elaborate more about this later in my prone approach, how it's useful for example, for vestibular schwannoma, identifying the transverse sinus and the sigmoid sinus. And limits of the foramen magnum as well is useful to know the inion posteriorly and the anterior border, which is the basion. Okay, so moving on to clear operative field. Really, this is to make sure when you're positioning a patient, you have at the back of your mind that you don't over flex and over rotate a patient to prevent kinking of the internal jugular vein, as this would cause a buildup in venous pressures and also reduce cerebral perfusion pressure. So there's a lot of biomechanics and mathematics models that have been discussed in literature, but I won't go into the details of it. But the graph at the side shows you the different positions and the different ICP and perfusion pressures that come with it. Another consideration to note is also in terms of cervical manipulation. You need to know whether the patient underlying has unstable cervical spine or cervical myelopathy. So you need to be careful in handling such patients. And also during intubation, if you need to, you may need to ask the anesthetist to do an inline intubation or a wake fiber optic intubation. Okay, so talking about equipment, I just want to have a brief run through of it because as a junior resident, you might not be aware of all the instruments that are available to you. These are really the basics of what you need to know as a junior resident, really. So I'll be talking about frame, and the adjuncts I'll discuss more in the positions later. So in terms of frame, we have the Mayfield and Doro frame, which it is used very commonly in a 3-point fixation device system. So it's one of the more commonly used skull clamps today, and it's really a fixation device that allows us to clamp a patient's head in operating theater, make sure it doesn't move when we're operating, and also allow us to do a neuronavigation accurately. So the 3-point system is made out of really 2 components: the swivel rocker arm, which is this 2-pin 360-degree rotation locking mechanism, as well as a contralateral single pin and a quick release lock at the bottom. And the idea of it really is to fix a point. You have the 2 pins in front and 1 pin at the back. And in my drawing there, you essentially want to let the single contralateral pin be equidistant to the 2 pins, such that the center of gravity, or rather where it's centered, is equal to each other. And the second point to note, of course, is when you're positioning a patient, the pins should be below the equator so that there's no slippage when you fix a patient in position. There's the additional body halo retractor system, which may not be available to all, or not everyone uses it, but it is an option to add on. So you can have the C-clamp adapter as shown there, and the halo and support rods as an add-on. This provides the system for you to have retractor arms and blades such that you may not need an assistant when you're retracting. So moving on to the Sujita frame, this is another device that we commonly use. As you can see here, there are many parts and attachments, but the point is the same. The difference between this and the 3-pin skull clamp is that this one actually has more options. In a sense, there are actually 6-pin sites that you can use, and you would use 4 out of the 6 at any one point of time, and you would position them, rather you would pin 2 pins at a time, opposite and equidistant to each other. And again, the aim is really to center the lesion in the middle. You also have the attached construct together with it, the basal frame and the retractor system that we use. Okay. In terms of pitfalls of pinning, I think this is important to note. There are areas of vulnerable bone when you are pinning, and it's important to take note of the frontal sinus specifically, as well as the squamous temporal bone, which is especially thin. So if you fracture through it, you really need to or rather you really need to take note of the landmarks before you actually start pinning a patient. And all craniotomy sites, definitely, you need to, based on your CT that you have done before and based on palpation, really avoid the lines where it has had, B1 go through it before, because you can plunge straight into the brain. Of course, you have to make sure there are no additional devices such as shunt tubings or even the valve pump itself. And really, for safe fixation, you need at least 1 pin below the equator of the head. Okay, horseshoe frame is something you can also use. It's slightly easier to maneuver. It has a vertical and lateral adjustment, and really it's quite easy to use, but definitely not as fixed as a skull clamp or a Sujita frame. Okay, so now moving on to positions itself. Like I mentioned before, I'll be talking about supine straight, supine head rotated, lateral, prone straight, and the 3/4 or park bench approach. So decided to make it a more practical approach. So for the supine position, really this is something that junior residents would have to be very familiar with, because you would use this for positions for EVD or ICP monitor insertions. It's really in a neutral position where a patient is supine on a donut, and you shave the head to identify the midline, and thereafter you draw out the Cocker's point, and this is a 10-3, 10 cm from the nasion and 3 cm from the midline to correspond with the mid-pupillary line, really. And then you aim your EVD in the trajectory. And yeah, Another example of supine neutral or supine straight that we can do is really for bicoronal craniotomies, and this can be done electively. So, if, for example, if you have a cribriform meningioma, you would want a bifrontal approach, or even for bifrontal craniotomy, as in the CT below. The main point to note, I think, for this elective clamping procedure is usually the pins come very near to the incision site. So you really do need to mark out your hairline, your incision site, the coronal suture, and make sure when you pin, you avoid the incision line and give enough space for your draping to come on after. Okay. The supine head rotated position, this is another common one for junior residents, essentially for chronic subdurals, where you just need a bit of head tilt really to make the parietal eminence or irion more prominent. From there, you can do your two boreholes, the frontal and the parietal borehole, as in the photo here, or if you need to do a small mini craniotomy, that's possible as well. The supine head rotated, which requires a lot more head rotation, would be, for example, for a decompressive craniectomy. It may not be as commonly done, but it is something that you will need to take note of. So for these positions, because there's so much head tilt involved, you would need a much larger shoulder roll, such that when you are rotating the head, you don't over kink the neck and kink the IJ vessels and cause worsening of venous congestion and bleeding. But really, the head tilt is required so that you can make a large reverse question mark incision and have adequate exposure of your parietal eminence, but also able to see your midline, really. Okay, so one of the most common procedures that we use in the workhorse in neurosurgery is the pterional approach. This is something that we use for we use for our aneurysm cases as well as a lot of our tumors. Essentially, this can go anywhere from a 30-degree, 45-degree to a 60-degree head tilt, and all this depends on what kind of excision you're hoping to achieve. So for the important thing to note for this, I guess, is you want to avoid over-rotation of the head, as this causes the temporal lobe to lie over the sylvian fissure. So if you are trying to dissect through, identify a sylvian fissure and dissect through, you would not want too much of a head rotation as you would for another procedure that you are trying to access more temporal lobe for example. And also need to take note that overextension of the head may also result in obstruction of view by the orbital rim. So these are just some considerations to take note of. Okay, a lateral approach. So this is where the head is mostly in a neutral position, may be selected for more of middle cranial fossa skull-based approaches. And the use of a lateral approach really just lessens the blood pooling in the surgical field, because you have a relief of pressure from the abdomen, and this decreases the compression of the vena cava, reduces the intra-abdominal pressure, and also by gravity really just allows better drainage. Prone position, this is something that we commonly use for unilateral or bilateral suboccipital craniotomies, as well as for cerebellar, fourth ventricular pathologies of the pars fossa. Some examples, I put up the scan there of a bleed and a tumor. But essentially for this, the positioning would be a military tuck position, where you extend the neck and flex it, and you would need to do it adequately to expose the C1 up. If not, if your patient is not flexed enough, you will not be able to visualize it when you're doing the surgery. But to take note of that, you also cannot do it too excessively in case you kink the ETT tube or kink the IJ. So usually we would say 2 fingers breadth between the chin and the sternum. Okay, so the park bench approach, this one would be the 3/4 prone approach. You can use this really for exposure of posterior parietal, occipital, lateral suboccipital, cranial cervical junction at some points. And really this approach is quite widely used for vestibular schwannoma, MVD, for example. So one of the important landmarks that I just wanted to highlight when we're doing this procedure is really to be able to identify the transverse sinus and the transverse sinus sigmoid junction. The way we draw out the transverse sinus really is from the zygomatic root to the inion, and for the And for the sigmoid sinus is a digastric point. So this is the superior aspect of the mastoid notch. And in the bony landmark wise, the asterion marks out the transverse sigmoid junction. So usually you use that as one of the burr holes when you're approaching this. Okay, I guess the pitfalls for this position, again, number one is the head flexion, the kinking of the IJETT. But on top of that, because for these kind of surgeries, usually they're slightly longer. And as you can tell, the position is not in a neutral position. There's a lot of issues with pressure sores, a lot of padding, chest padding, shoulder padding, even pillows under the feet, under the legs and between the legs have to be provided. So there are a lot of pressure points and pressure sores that we would need to avoid. The second thing is really for nerve palsies as well, the axilla, radial ulna, brachial plexus also. So all these need to be padded with foam, or you will need to put gel paddings on to avoid these as well. Okay, so I think I've come to my conclusion of what a summary of positioning that a junior resident would really need to know for their neurosurgical training. So just a recap, you need to think about principles of ideal positioning, the procedure and fixation methods, and for that you need to be familiar with the equipment you have. The various positions, the ones that I've gone through really are the standard positions that we use in everyday practice, and something that you would really need to be very familiar with. And with that, I come to the end.
Thank you, Felicia. That was fantastic. So if anyone's got any questions, please put them in the chat. I've got one question from Dr. Deepak Jha, who, sorry, you might see my dog in the background here. She's deciding to have a chat with me. Dr. Deepak Jha, who's asking why only use 3 pins in the Sagitta frame instead of 4? 3 pins don't give sufficient stability. Although I must admit, I always use 3 pins. I haven't had any problems yet, but have you had any experience with 4 pins? And maybe your mentor, Dr. Kyrilos, might also want to help answer there.
Okay, for the Sagitta frame, actually, we usually have the practice of using 4. I think the 3 pins, I did mention it was more for the skull clamp, but maybe Mr. Ramesh can comment about the 3 pins if he's...
Yeah, the Sagitta has 6 slots, which we use 4 at a time, 2 opposite each other diagonally, which you tighten diagonally at the same time. So you can always, 4 will make it stable. You can use 3. And the beauty of eliminating 1, because you have some patients who have multiple craniotomies and there is a bone gaps. And sometimes it is not correct you want to really to avoid, and even with your 6 choices, you cannot avoid certain gap in your previous craniotomy holes in cases of revisions. So you have the option, but usually we use the 4 and the Sagitta rather than the 3. But for the Mayfield and the Doro, 3 will be enough, provided, as Felicia said, that you don't put the whole pins superior to the equator, otherwise the head will slip down.
I've got 2 very relevant questions here for the junior residents. Felicia, the youngest age limit for a patient to be pinned? Felicia?
Oh, sorry. Oh, okay. The youngest age limit really, we cannot pin less than 3. That's my understanding.
3? I'd probably go a bit older. Any advance on 3?
Sorry.
Dr. Kyrilos, would you pin a 3-year-old, or maybe wait a little while?
I lost. I couldn't hear the question.
What's the youngest age you can pin?
Right. Okay. So below 5, you have to be careful. And of course, neonates, you will not do it. But below 5, you have to be careful. But some positions, if you are doing a vascular procedure that you need really fixed procedures, then you use the special pediatric pins.
Yeah.
But these are not designed even for neonates or young people. So the pediatric pins have a shoulder on it, rather than it's completely like a conical in shape, so that they do not penetrate the inner table. They have like a safety stop on it.
Okay, so we've got somewhere between 3 and 5, but with great care below 5. And Felicia, one more question here. I'm gonna stop it at this one after this one and move on to the next. What position would you use if the patient had bilateral subdural hematomas?
We would standardly use a neutral supine. Yeah.
Yeah, and that's what we'd use as well, neutral supine. Okay, Felicia, thank you very much for your presentation. That was fantastic. You guys, you've got great residents there in Singapore. All of the presentations I've seen so far have been excellent. So our next presentation is Dr. Jensen Ang. If you can please share your screen there, Jensen. And I'm fascinated to see, now remember, you only have 20 minutes because I'm fascinated to see how we can get all of the common neurosurgical emergencies in about 20 minutes, but off you go. Well done.
Hey, hi everyone. My name is Jensen. I'm one of the senior residents here in NNI. I will be talking about common neurosurgical emergency today, but I chose this topic because I feel that as a junior resident or someone starting out in neurosurgery, it's helpful to kind of know what to prioritize and look for. So what we're going to cover today really wouldn't be the whole, comprehensive, variety of all neurosurgical emergencies, but we're just going to focus on 4 main scenarios: injury, hemorrhage, as well as hydrocephalus. And essentially what we hope to establish at the end of today will be to have a systematic approach to event and management of these neurosurgical emergencies. So first and foremost, I think what we need to remember is that the brain needs these 3 things in order to function. So oxygen, glucose, as well as perfusion. And ischemia or irreversible injury can occur if any of these factors become inadequate. So going back to what my colleague Dr. Chong mentioned last week in his talk on ICP, the Monroe-Kelly doctrine highlights an important principle, and that is that the skull cavity is a fixed space. It's filled with brain, CSF, and blood. And any expanding space-occupying lesion first decants CSF and then venous blood. And once it starts to decant arterial blood, that's when our patients start to decompensate and to deteriorate clinically. I will get back to this later on in my presentation because it's important in terms, especially in terms of traumatic brain injury. But the principles of management of all neurosurgical emergencies really will be to evaluate the patient, predict the possible consequences based on the degree and the type of injury, and then treat them before the consequences become irreversible. So let's start off with head injuries first. Traumatic brain injury constitutes a major cause of death and disability in all ages. And this incident has been steadily increasing both in the developed world as well as developing countries as a result of increased motorization as well as an increase in force. And the important point in history taking would be the mechanism of injury as well as whether the patient experienced any seizures prior to getting to the hospital, because these factors could provide clue as to how the patient would eventually progress. In terms of examination, I think the important point would be the GCS and the pupils. Now we can do a much more comprehensive history if the patient was well, but given that this is an emergency, you want to focus on the most important parts that will help you make a decision quickly. In terms of investigation, we definitely need a CT hit. So just a quick discourse about the GCS. The important point to remember is that it is the indicator of global and not focal brain function. And the problems include that it has a high variability between observers, and There are many ways that people do test it and grade it, but the key point would be that you have to use a stimulus that is central and cannot be influenced by spinal reflexes. So using a sternal rub or supraorbital notch pressure will be far better than a peripheral state pain stimulation, for example. You should also take the best response in an adequately resuscitated patient. And problems aside, the GCS is actually a very useful indicator, especially the motor component, on how badly the brain is damaged. So going on to traumatic brain injury, once we have done the evaluation of the patient, we go on to essentially classify the types of injury that has been sustained. And here I have split them mainly into two categories. So primary injury as well as secondary injury. Under the localized categories, you have fractures, vein tears, contusion, and ICH. You also could have diffuse injury. I mention it as diffuse injury because if we only get the diagnosis of diffuse external injury in a post-mortem examination, so we will just call them diffuse injury for initially. And if these potential factors are not treated or addressed, then they could go on to lead to result in secondary brain injury. Okay. So traumatic brain injury is unique in the sense that in an injured brain, it reacts very significantly to only a very minute change in oxygen or glucose levels or perfusion. And therefore, ensuring adequate oxygenation and perfusion to the brain at all times is very important. So the first question that you'll be asked would be whether or not the patient has to be intubated, whether the airway has to be secured. If you remember the pressure volume curve that I showed earlier, as arterial blood volume starts to decrease because of the buildup of space occupying lesion or the intracranial pressure, it could still be, the ICP could still be normal, but the patient could already be becoming drowsy because of ischemia. So the most reliable indicator of how injured the patient's brain is still a clinical assessment of his GCS. If we pop an ICP, if we sedate the patient, the ICP helps in terms of measurement, but it only responds a bit later compared to clinical deterioration. And therefore, in this case, it's a balance between wanting to protect the airway before hypoxia sets in a traumatic brain injury patient versus the ability to assess the patient GCS when he's not intubated. And therefore, if we are considering when to intubate the patient, I think the strong indicators will include a low GCS of less than 8, a deteriorating GCS, a rapidly deteriorating GCS, because eventually you know that the patient is going to end up not being able to maintain his airway and hypoxic. If there's already signs of hypoxia or if the patient suffers from a seizure. Now, relative indications would include scenarios where the patient is very combative or agitated, or if, let's say, you are actually planning to move the patient from a location to another, for example, on his way to the operating theater, then you could electively, not say electively, but you could elect to intubate the patient earlier to kind of secure the airway before the transfer. And then finally, if there are other external injuries that could cause the patient a great amount of discomfort, and you will need to keep the patient sedated or under strong anesthesia, then you need to be mindful of the side effects of these medications and possibly elect to intubate them early as well. But otherwise, management of a head injury patient is relatively straightforward. We ensure good oxygenation, so we intubate if necessary to protect the airway and respiration. We ensure good perfusion to ensure that there is normal blood pressure and no ongoing blood loss. And then essentially we control the pressure within the skull. If there's a focal lesion that is causing significantly raised ICP, then surgery should be done to evacuate it. If it's actually just mainly diffuse swelling that is causing a rise in intracranial pressure, then my colleague Dr. Chong, I think, addressed this adequately. We manage it using our 3 tiers of ICP management. So that's it for head injury. I'll move on to ICH next. So intracerebral hemorrhages is a very common problem that we see in our institution here. It accounts for 20% of all strokes, and its incidence is also projected to increase with our aging population in Singapore. So in the history itself, we want to find out the time of onset, if there's a history of high blood pressure or hypertension, and if there was any prior use of antiplatelet or anticoagulation. When examining a patient, I think the GCS as well as the focal deficit that the patient has will be the key finding to pick up, because it gives you clues as to where this clot is actually located inside the brain. And investigation of choice here is the CT brain as well. Now, there are many causes, but I think what I'm trying to point out here is that hypertension as well as amyloid angiopathy in the elderly are the two main causes of intracerebral hemorrhages that we see here. The other less common causes, such as the MCA aneurysm rupture, tumors, AVMs, or even venous sinus thrombosis, they do occur, but they are less common. And essentially, intracerebral clot should be regarded as an acute life-threatening event, because even if presenting symptoms can initially appear mild, hematoma progression can lead to rapid neurological deterioration. So the presence of a clot would in turn also cause edema around it, and the ensuing hemoglobin and iron toxicity as the clot breaks down eventually also causes death of neurons around it. So if the hematoma size is significant, it will also exert significant mass effect to the surrounding brain parenchyma, and that also causes ischemia. So the key aspects to managing intracerebral clot really is to stabilize the patient's vital functions. Then we identify and treat the underlying bleeding source. There will be a need to control any kind of elevated intracranial pressure. And then we institute specific treatments to limit hematoma progression. So, for example, we keep the BP under control to reduce the risk of hematoma expansion. We also treat any coagulopathy. In our practice here, we tend to give platelets for patients on antiplatelets. We reverse any kind of prolonged clotting time as well. And then finally, the question of whether surgery is needed will have to be answered. So, which brings us to the question why we should operate on an intracerebral clot. Now, as you can see here, just by having an intracerebral clot, it starts a whole cascade of events. And therefore, if it's likely that the clot size and the expectant edema that ensues, if it's going to cause significant mass effect as well as herniation, or it leads to significant brain injury around it, then evacuation of the clot actually reduces the likelihood of these happening. So we've kind of identified 5 main factors when selecting appropriate surgical candidates. They are namely age, the hematoma size, the patient GCS on admission, the location, as well as their clinical course. I think this is quite straightforward. We tend not to operate on the very old. If the patient is very well, or if they are already showing signs of brain stem herniation, posturing, for example, then we do not operate on them as well. If the clot is extremely small, or if it's massive, then we will not operate on them. If the location of the hematoma is very deep, maybe even within the brainstem or in the thalamus, we do not operate on them. And finally, looking at their clinical course, if they were well throughout, there's no indication to suggest an operation. If they were already moribund from the beginning, then I think the operation might not also benefit the patient. That was in the case of a supratentorial ICH, and in infratentorial ICH is quite similar. Yeah, I think the additional point I wanted to highlight is that, given that in infratentorial ICH, usually a cerebellar clot, if it's not within the brainstem, sometimes the posturing could be just a sign of direct compression on the brainstem pyramidal tracts. So in these cases, sometimes it is beneficial to offer surgery, because rapid removal of this compressive effect actually more often than not, the patient do improve. And then finally, another kind of rationale for offering an operation would be if the clot is actually causing obliteration of the fourth ventricle, leading to hydrocephalus. So in those cases, we could either elect to take out the clot if it's massive, or if it's small but still causing significant compression to the fourth ventricle, then a ventriculostomy will help. Now let's move on to SAH now. So patients with a ruptured aneurysm could die before they reach the hospital. They could also present merely with symptoms of a sudden onset headache, nausea, vomiting, or drowsiness. So the key point during an evaluation of these patients will be the GCS and the presence of motor or speech deficit, because that influences your WFNS grading. CT will provide information based on the distribution of the bleed, whether there's a presence of intracerebral clot, such as in the case of MCA aneurysms itself, or whether there's the presence of hydrocephalus, which would necessitate ventriculostomy. And then moving on, in our institution, we very commonly elect to do a CT angiogram at the same time, because that gives us a rapid diagnosis as to where the aneurysm is. The consequences of the aneurysmal subarachnoid hemorrhages are as follows. So sometimes patients do get very significant cardiac stunting from the catecholamine surge, and also neurogenic pulmonary edema. Hydrocephalus is a possibility. In the ensuing hours to days, then we start to get more worried about a re-rupture of the aneurysm. And seizures, electrolyte abnormalities are also some of the more common consequences that we see. And then finally, in the ensuing days, delayed ischemia due to vasospasm can also occur. So the two kind of main grading scales that would be very helpful in terms of predicting the patient prognosis as well as the likelihood of vasospasm would be the WFNS score, as shown here, as well as the modified Fisher scale. And management of good grade patients is quite self-explanatory. Essentially, we are managing the consequences of a ruptured aneurysm. And so cardiac stunting and pulmonary edema sometimes require intubation or inotropic support. In the case of hydrocephalus, we put in a temporary EVD. If that persists despite after a few weeks, sometimes we have to shunt the patient. And then rebleed of the aneurysm is initially controlled by close control of the blood pressure to make sure that it's not too high. And then eventually we have to think about coiling or clipping the aneurysm to secure it. Once the aneurysm is secured and we start to raise the blood pressure, increase the hydration in order to prevent vasospasm and delay ischemia. We also sometimes provide some intra-arterial nimodipine infusions in the case of patients who go into symptomatic vasospasm. Now, the management of poor grade patients a little bit more contentious. So they have a poorer prognosis, and therefore one of the things that we know can complicate GCS assessment could be hydrocephalus. So if there is acute hydrocephalus, we will put in an EVD and we will see whether the patient improves. If they improve to the good grade, to the good grade criteria, then we could go ahead and treat the consequences of SAH just as before. But in some of the cases, without any improvement, sometimes we would opt to palliate them. Now, there's a few special circumstances in SAH, and they tend to apply more to the grade 3 hemorrhages. So sometimes patients who are initially good grade, but they have an MCA aneurysm rupture resulting in a clot can present with hemiplegia or hemiparesis. Now, in these cases, if the clot is actually causing significant mass effect, then there is a plan to actually evacuate this clot, then clipping can be done at the same time as well. Now, if the hemiparesis or the dysphagia was due to ischemia, however, then we will aim to secure the aneurysm as quickly as possible, either through coiling or clipping, followed by instituting hydration as well as high blood pressure in order to reduce the the extent of ischemic deficits. And finally, moving on to hydrocephalus. I think this is quite self-explanatory. The symptoms include headache, nausea, vomiting. On fundoscopy, you might find papillary edema. And I think the main kind of special circumstance to highlight will be if the patient had previously had a shunt, because the shunt malfunction very often. And so if we were suspecting a malfunctioning shunt, then these are some of the investigations we can consider. So a shunt series X-ray to make sure that there's no disconnection or kinking of the shunt tubes. We can do a shunt tap to see whether or not the proximal portion is actually still patent. And finally, we can consider CSF infusion studies as well. So that brings me, management, I think, is quite self-explanatory. Essentially, we have to relieve the hydrocephalus either through a temporary EVD or a more permanent shunt insertion. That brings me to the end of my presentation. I think I've covered the main kind of nuances and priorities in head injury, ICH, SAH, as well as hydrocephalus. And just to remind us that medical treatment is mainly about predicting the consequences and treating them before they become irreversible. Thank you very much, and I hope to answer any questions you might have.
That's a great picture. Jensen, I really liked your, I hate to make you go back, but can you go back one slide, even as much as I like that picture? So I think when you see, you know, when you see a lot of junior residents or interns see patients, they get to the evaluate, but the most important next step in the development of becoming a neurosurgeon is to predict the consequences. And that's, I think, the real cognitive jump from being able to just examine the patient and say what you see, to examining the patient, understanding the disease and knowing what will happen next and do something about it. So I really like the way that you've put that out there. I've got an interesting question here. When the patient is intubated, do you always ventilate or just give oxygen? I think that's probably most of the time you'd ventilate, but any sedation or muscle relaxant given to intubated patients?
I think that depends on the status and the condition of the patient. If we want to keep the patient minimally sedated in order to assess them clinically, then we basically give a minimal dose of normally fentanyl so that they can tolerate the tube. And essentially, we keep them minimally sedated so that we can assess their GCS. If it was a scenario where we wanted to control what we know to be high or raised cranial pressure, then sedation actually the first step in the management that we institute in our institution in order to address the ICP.
Yep. And one other question, is there a role for TXA in intracerebral, so tranexamic acid in intracerebral hematoma?
No, there isn't. But we are actually doing that for some of our SAH cases as well over here.
Okay. All right. Thank you, Jensen. That was a tour de force of 4 important conditions in about 20 minutes. But as I said, the 2 most important slides were your boss kissing a skull and which I think is fantastic. And the predict that, you know, what's going to happen next after the evaluation. The number of times I get called in the middle of the night by someone who says, oh, I've got a patient with this and this and this and this, and it's a beautiful evaluation. Then it's like, okay, and next. And that's the next step that's so important to get straight in your own mind. Okay, so our next presenter is Dr. Colin Lowe. And his mentor is my old colleague, Dr. Peter Huang. Hi, Peter, if you're there somewhere. So Colin Lowe is going to talk about principles of sodium management. Now, Colin, if you can get this right and make everyone understand sodium management, you will be doing particularly well, because I still don't really understand it. So I'm looking forward to it.
Hi, Kate. Warmest greetings. I'm very happy to see you again.
Oh, hey, Peter.
Yeah. So it's really wonderful to see you again, and we'll touch base more privately.
Okay.
Yeah.
All right, Colin, are you ready there? Can't hear you, Colin. Wait a minute. You're going to have to unmute yourself.
Yeah, Colin, there you go.
Okay, there you go. You'll need to put, yeah, that's it. Great. You ready?
Okay. Thank you, Dr. Drummond and Dr. Huang. My name is Colin, and I'm presenting on sodium management in a neurosurgery patient today. So why this topic? Because I think it's very important at the junior resident level. One of the most common medical issues affecting the neurosurgical patient is actually sodium disturbances. And also because I feel that the perioperative management of a neurosurgical patient is just as important as the intraoperative technical aspects. And that's what makes our patient go home happily and early. So the learning objectives for this set of slides, I hope that everyone will be able to recognize the common sodium pathologies affecting the neurosurgical patient. And I hope that to help you guys to be able to identify the various assessments needed to evaluate for sodium disturbances. And I hope that you guys will be able to be aware of the treatment options available for the various sodium disturbances. So this is a busy slide, but let's just go through each of them one by one. So this is a simplified hyponatremia algorithm. So first, to prove hyponatremia, we need a sodium of less than 135 millimoles per liter. And subsequently, we divide them into symptomatic or asymptomatic patients. In symptomatic patients who present with confusion, seizure, coma, or obtundation, we usually just go straight to treating them with 3% hypertonic saline till the symptoms resolve, taking care not to exceed beyond 6 to 8 millimoles per liter per day. In patients who are relatively asymptomatic or have only mild symptoms, like headache or giddiness, then we need to do further evaluation before we start treatment. So we first evaluate them by determining their serum osmolality. And if their serum osmolality is normal, then we group this bunch of patients into isotonic hyponatremia, or what we call pseudo-hyponatremia. In these patients, you need to consider hyperproteinuria or hyperlipidemia. And these patients are, for example, multiple myeloma can lead to increased protein, or familial hyperlipidemia may lead to increased lipids in the blood, which replace sodium as the dominant solute in the bloodstream. In our next set of patients, we have the hypotonic hyponatremia. This is part of some of our neurosurgical patients get this. And so after you determine hypotonic hyponatremia with a low serum osmolality, we need to assess their volume status next. And we do this by examining their jugular venous pressure, their orthostatic blood pressure, and their skin turgor or their mucous membrane. And if you establish them to be hypovolemia, you next look at their urine sodium. If their urine sodium is high, above 20 millimoles per liter, you consider renal losses like drugs or something what we call cerebral salt wasting, which I'll come to later. If their urine sodium is low, that's when you consider other causes like vomiting, diarrhea, or insufficient intake. The treatment for both conditions are also isotonic saline, but it's still important to differentiate them so you can reverse the underlying cause. In the next subset of patients with hypotonic hyponatremia, we have patients who are euvolemic, which means that their volume status is pretty normal. The important one for neurosurgical patient is actually patients with a high urine osmolality, and this is more than 100 milliosmol per kilo. And the important thing to look out for here is syndrome of inappropriate antidiuretic hormone patients, which are very common in neurosurgical patients. The other smaller subset is actually patients with primary polydipsia or low solute intake, in which case their urine osmolality will be low. The treatment for both conditions is fluid restriction. The next subset for hypotonic hyponatremia are patients with hypervolemia. This is predominantly a medical cause, so I will not go into much detail, but the treatment for these patients are actually fluid and sodium restriction along with diuresis or dialysis. And so for patients with a hypertonic hyponatremia, which means they have a high serum osmolality, you need to assess them for hyperglycemia and the use of mannitol or radio contrast media. Again, this hyperglycemia or mannitol can replace sodium as a solute in the bloodstream and cause your hypertonic hyponatremia. So let's just go to a few cases that I have for today. So case number 1 is a 78-year-old female who slipped and fell at home, and the CT brain shows bilateral frontal contusions. This is currently the day 3 of admission, and you have reviewed the patient and assessed her to be euvolemic on assessment. However, her serum sodium is low at 123, her serum osmolality is low at 257, her urine osmolality is high at 562, and her urine sodium is also high. Her thyroid function tests and 8 AM cortisol are both normal because we're trying to exclude hypocortisolism and hypothyroidism. So in this case, we have a diagnosis of hyponatremia because the sodium is 123. She's relatively asymptomatic, and she's also hypotonic hyponatremia because the serum osmolality is low. We have evaluated her to be euvolemic, and her urine osmolality is 562, which is high. So in this case, her diagnosis is actually SIADH, and the treatment here is fluid restriction. So what is the etiology of SIADH? So any intracranial insult can cause release of ADH from the brain. So there's a theory that this is mainly evolutional, because in the past, if you have a traumatic brain injury during the hunter-gatherer times, this bunch of people who have TBI might not be able to hunt for food or water. And in this case, the ADH response to reabsorb free water is actually, it helps to conserve water in the body and helps survival. So ADH acts on the collecting tubules, the V2 receptors of the collecting tubules to reabsorb water. So then the question comes, why do these people have euvolemia and not hypervolemia if you say that they reabsorb more water? So you have to go back to the pathophysiology of SIDH. So you start off with the inappropriate ADH release, which causes more free water reabsorption in the collecting ducts. This actually correspondingly leads to an increase in the intravascular volume. And when the intravascular volume goes up, it leads to a secondary natriuresis mediated by atrial natriuretic peptide, because there's increased cardiac atrial filling. And subsequently, this leads to a disproportionate loss of sodium compared to free water due to the secondary natriuresis. And therefore, the patient gets euvolemic hyponatremia, and their urine will be more concentrated, which leads to a higher urine osmolality. The workup of SIADH is very simple. So we first assess the patient's fluid status, including the intake-output charts for the last few days, because that's the most important is the clinical status of the patient. Secondly, we establish the likely etiology. Is this poor oral intake, or is this likely to be caused by secondary things like SIADH? And then we do the patient's labs, so the renal panel, the random glucose, because you want to correct for any pseudo-hyponatremia, and you also take the urine osmolality paired with this patient's urine osmolality and the urine sodium, along with the cortisol and thyroid function test to exclude other secondary causes. And the treatment of SIADH is very simple. It's fluid restriction is the key. In our institution, we do use salt tablets as an adjunct to help to bring up the sodium a little bit faster. And also you can consider the use of hypertonic saline with an ICU or endocrine consult if needed. In the literature, there's also use of vaptans and the macrocycline. The vaptans are a class of drugs which directly act on the V2 receptors in the collecting tubules to block it and prevent the action of ADH. But we don't really use it in the Singapore context. The next important thing to do for the treatment is monitoring. So you monitor their strict intake output to make sure that they're properly fluid restricted, and you give them a high protein, high salt diet to try to increase the amount of solutes in their bloodstream. And usually you will trend their sodium daily until it uptrends nicely, and then you loosen the fluid restriction along the way as the SIADH response improves. Case number 2 is a fairly similar history. So 78-year-old female who fell and had bilateral frontal contusions. This time when you examine her, you see that she's quite dry. Her mucous membrane is dry. She has poor skin turgor. And if you look at her charts, she's refusing her meals and not drinking much fluids. So her serum sodium is low. Her serum osmolality is also low. Her urine osmolality is high, but her urine sodium in this case is low, is 18. So if you go back to the algorithm, we established that she has hyponatremia and it's relatively mild, and it's a hypotonic hyponatremia because the serum osmo is low. In this case, compared to the other one, she's hypovolemic and her urine sodium is actually low at less than 20 millimoles per liter. And this is consistent with her intake output chart of an insufficient oral intake. So the treatment for her is isotonic saline and encouraging her to eat and drink more. Case number 3, again, a similar history. In this case, the patient is also dry, skin poor turgor, and a mucous membrane is dry. Her serum sodium is also low, and her serum osmolality is low, which is hypotonic hyponatremia. Urine osmo is high, and the urine sodium in this case, compared to case number 2, it's much higher than case number 2. If you look at her intake output charts, she has passed over 2 liters of urine over the last 12 hours, and she's negative 3 liters over the last 24 hours. So this is a case of cerebral salt wasting because it's a hypotonic hyponatremia. She's hypovolemic, but in this case, her urine sodium is high, which means that she's actually losing both sodium and water in her urine. And the treatment for her is isotonic saline. A little bit more about cerebral salt wasting. The pathophysiology of cerebral salt wasting is the insult to the brain, which causes the release of brain natriuretic peptide. So after the release of the brain natriuretic peptide from brain injury, the BNP leads to increased glomerular filtration rate and decreased renin, angiotensin, aldosterone system. And both of these leads to increased natriuresis and diuresis, and this results in an overall hypovolemia and hyponatremia. The treatment of this is just by replacing fluid losses in the urine 1-for-1 with isotonic saline, and to continue this treatment until the underlying insult resolves, usually when the brain injury recovers. So currently there's no direct pharmacological modality of which we can block the release of BNP. Just one slide on severe hyponatremia. So the classical signs and symptoms are seizure, confusion, obtundation, coma, or respiratory distress. And usually patients with these signs and symptoms usually have a sodium of less than 125. The treatment is stat administration even before investigation with 3% hypertonic saline, and is usually enough to just increase their sodium by 2 to 3 millimoles per liter, and this allows patients to cross the symptomatic threshold. So again, another caution: do not correct the sodium by more than 6 to 8 millimoles per liter over 20, because of the risk of osmotic demyelination syndrome, which is in the past used to be called central pontine myelosis. Case number 4 now. So it's a completely new case. It's a 48-year-old female with a non-functioning pituitary macroadenoma. This is her day 1 of her post-op of her transsphenoidal endoscopic resection. She has high urine output over the last 2 hours of 250 mils and 270 mils respectively. Her serum sodium is high at 147. Her serum osmolality is high at 313. And her urine osmolality is very low, is below the reference value, and her urine sodium is actually pretty normal. Her diagnosis here is diabetes insipidus. Let me explain to you why. In diabetes insipidus, usually the diagnosis, you need a high urine output, usually more than 200 mils per hour over 2 consecutive hours. You need a diagnosis of hypernatremia, 145, which she fulfills. You also need a diagnosis of hyperosmolality, which she fulfills. And you also need, the key thing here is that you need a urine osmolality which is lower than her serum osmolality, which indicates a failure of appropriate water reabsorption response at the collecting tubules. Only then can you prove a diagnosis of diabetes insipidus. In this case, she has hypernatremia, is hypertonic hypernatremia, and her urine osmolality is much lower than her serum osmolality, and so the diagnosis is diabetes insipidus. The differential diagnosis for a patient with high urine output is actually post-stress or post-surgery fluid mobilization. After they're extubated, they do get some fluid mobilization, but these patients usually have a normal tonic normal natremia, and the urine osmolality is usually proportional to their serum osmolality. The next differential diagnosis is psychogenic polydipsia, but these patients with high urine output usually also has a hyponatremia. So the treatment for diabetes insipidus is drink to thirst. So most of our post-pituitary surgery patients, they are usually alert and able to drink to thirst, then they should do so. However, in some patients with very severe brain injury and pituitary damage, they might be completely obtunded. and with no thirst response. In this case, you might need some desmopressin to augment their diabetes insipidus. So just some differences between vasopressin and desmopressin. So vasopressin is the intrinsic peptide hormone produced by the posterior pituitary gland, and desmopressin is actually the synthetic version. They did some deamination and some and change the arginine at the 8th position. So the action of vasopressin is actually both a vasoconstrictor, as the name suggests, and also prevents the water and also helps in the water reabsorption. However, desmopressin is a selective V2 receptor agonist, so it doesn't give you any vasoconstrictive properties. The vasopressin half-life is much shorter than desmopressin half-life. So desmopressin, you can just give a bolus dosing, whereas vasopressin usually requires a continuous infusion. And vasopressin is more limited in its modes of administration. You can usually only give it intravenous or subcutaneous, whereas desmopressin, you have other routes like oral or intranasal, which we use quite commonly in our center. So case number 5, this is a 48-year-old female. She has the same surgery. In this case, her urine output was 250 mils and 270 mils over the last 2 hours. Her serum sodium is 147. Her serum osmo is 313. Her urine osmo is 352, and her urine sodium is 21. So in this case, this is post-surgery fluid mobilization, because her urine osmo is fairly similar to the urine with the serum osmo. So she is actually still concentrating her urine appropriately. So if you see here, she only has high urine output, whereas actually her sodium, actually I got the values wrong. I meant to put that her serum sodium is actually normal and her serum osmo is actually normal, together with a normal urine osmolality. So this is actually just post-surgery fluid mobilization. So in a lot of the pituitary patients, most of the high urine output usually is post-surgery fluid mobilization rather than diabetes insipidus. But it's very important to look out for diabetes insipidus because it can potentially lead to morbidity and mortality. So in summary, the 3 most important sodium disturbances in a neurosurgical patient, number 1 is SIADH, and this is classically a euvolemic hypotonic hyponatremia with a high urine osmolality. In mild cases, the treatment for this is fluid restriction, and in severe cases, we use 3% hypertonic saline. The next important sodium disturbance is cerebral salt wasting, and in these patients, they get a hypovolemic hypotonic hyponatremia with high urine sodium and high urine output. And in this case, the definitive treatment is isotonic saline replacement 1:1 ratio. And the third most important sodium disturbance is diabetes insipidus, in which you will have high urine output, a hypertonic hypernatremia, disproportionately low urine osmolality. And the treatment for them is to drink to thirst. And if they are unable to, then compensate them with desmopressin. And the 2 things that you need to look out for our patient population also is the other masking conditions like poor oral intake or GI losses, which can lead to hyponatremia. And in high urine output patients, you have to exclude, even though you have to exclude DI, most of the times it's actually post-surgery mobilization. Any questions?
Thanks, Colin. That was fantastic. You had your most important point, I think, on your first or second slide, where you talked about how we really need to pay attention to all of the non-operative things in the management of our patient to keep them alive. And I think any idiot can learn how to operate, I think, but learning how to actually care for your patients and all the small details, the sodium, the temperature, the doses of the drugs. Have you started the right drugs? Have you stopped the drugs the patient doesn't need? Are they getting the physio's getting them up? Is their chest physio being done? All of those things. They're the things that will actually make your patients do well. And if you think that it's not real, in my hospital, within the last 10 days, a patient has had severe unrecognized diabetes insipidus, which, going back to Jensen's talk, everyone wrote down the numbers very well. Oh, there's a lot of urine here. Oh, this. But no one predicted the consequences of what they saw to severe detriment of the patient. So it's actually, those two talks go together beautifully. And, you know, that attention to those details is so important. Now, have we got any questions? Oh, we got an excellent lecture from Jorge Salazar. Have we got any questions for Colin? Because he's the man. Not everyone understands this sodium stuff, so he is the man. No, Peter, do you have any comments?
I think they need to take some time just to digest that flow chart, and maybe take a picture of it and store it in your phone. I don't know, maybe if Colin can. Are these lectures being archived, or can the participants access these lectures on YouTube or anything?
Yes, all the lectures. Yes, all the lectures are on the Neurosurgical TV YouTube channel. I'll put the address in the chat.
Yeah, so I think just encourage all of you to just take a picture of the flow chart and look at it and study it and carry it around with you when you next see a patient with a sodium abnormality. The other thing is just to look at your daily fluid input output charts, and weigh your patients daily as well if you're not sure, because often the patient's body weight will give you an idea, you know, whether they are hyper, hypo, or euvolemic. And if in any doubt, just call your endocrine or general medical colleagues for help.
So I think we've had 3 wonderful talks. Felicia has reminded us that everything in neurosurgery is about positioning and access. And if you don't set yourself up properly for that, then the whole case is going to go badly. Jensen's reminded us that we need to evaluate our patients, but not only evaluate them, think about what's going to happen next and act upon it, which is an incredibly important skill. And Colin has reminded us that the devil is in the detail for the care of our patients. Everyone can learn how to make the cut and take the tumor out, but the care of the patient and the detail of that is incredibly important. So I'd just like to thank our 3 speakers. Thank John Bennett for putting this all, making it happen. Thank our 2 mentors. And Wan Chu Sao, who's hiding there in the background from the Australasian Society, who's put this all together. And thank you everyone for participating. We are going to continue with these neurosurgery boot camps. We'll broaden them out a bit. I'll be making some of my residents do some presentations. So we'll continue with them because I think they're incredibly valuable. So thank you, everybody.
Thank you, everybody.
Okay.
Thank you.
Thank you.
Stay safe. God bless.
Bye.
Thank you very much.
Bye, Kate.
Bye.
Bye, Kate. Thank you again for waking up late, staying up late.
Yeah. Well, I'm going to put the address of the YouTube where they're archived.
Oh, thank you. Yeah.
These webcasts are all archived. Okay, let me get the channel.
It's just called Neurosurgery TV, right? Or something like that on the YouTube?
Yes.
Neurosurgery TV.
I'm going to give you the address, actually. So you just basically go there and subscribe. Okay. Yeah, and you automatically get all the videos that we do. So like any YouTube channel. Do you know we had a little bit of audio problems? Are any of the presenters here now?
Hello. Yes.
Yeah. Thank you. Wow, you covered all neurosurgical emergencies in 20 minutes. That's amazing. I don't have to do a residency, man. I just watch a couple of videos. I'm ready to go. No, the computer to the presenter. I'm sorry, the presenters. The computer power is borderline. You need to get a little more powerful broadband. And I gave Wan the address to check the speed of the internet. I'm going to put it in the chat right now, and I want you to run it on your computer and give me the download, the upload, and the ping. Okay, run that on your computer. Run that. It's actually a nice thing to have if you want to check the bandwidth of your computer that you're having problems. And give me values of download, upload, and ping.
John, I sent those to you already from the NNI where they were presenting. So as you said, the download and upload were a little bit on the low side.
Oh, okay. So it was decent. It was pretty good.
No, I mean it's the numbers are there on the chat that I gave to you. Yeah, not too good.
Oh, okay. Yeah, the borderline. There is.
Yes.
Some days that those numbers will work, but you're playing a dangerous game. If you have a lot of people using it, you're going to lose audio quality. You're going to lose video quality, etc. Well, Vlad, are you there?
Yes.
Yeah, Dr. Bennett, I'm here.
Yeah. Basically, what I'm doing now is I'm sending them a test that they can run your computer out. Now you can look at it too.
I've run it already. It's fine.
Yeah, you might have a good one. I have a good one, but occasionally you'll hello, Joanna. Occasionally you'll have borderline ones.
Yeah, I get it.
It should be like normally the 5 megabits should be your download. Upload should be 10 because the presenter is uploading material, uploading the presentation, and they need a good number. Yeah, when you're at the hospital now?
Oh, me? No, I'm at home.
Oh, you're at home. Okay.
Yeah,
your numbers at home are good.
Yeah.
You would not have the sound delays if you were presenting.
Yes.
That we saw. You saw them, right? Some of the sound. I thought, some days you have to keep your fingers crossed. We have a tool go well. For a while he didn't have a very good internet connection, and he's giving these big lectures to hundreds of people.
Yes.
And then occasionally his computer would just go down, but everyone would just wait. Everyone would just wait until he rebooted, started again. We rarely lost people. Oh, those are great numbers. Vlad, you have great numbers there.
Thank you very much.
Yeah, you see those numbers, right? You have no problems, right, with audio, video. The stronger it is, the less problems you have.
Right.
The lower it is, the more problems you're going to have.
Mm-hmm.
So
I think the next run we will actually have to discuss where they can do the
yeah, they might be able to move to a lounge or somewhere else it's closed.
They just wanted to be in the same conference room in the hospital. So
yeah, well, I hate to say it, but most hospitals are behind the times. They really need to boost the internet part. I mean, that's going to be one of the most important parts of the hospital. So they shouldn't skimp on that.
It is.
It's getting more popular.
The thing is big. because actually what's happening now is that our hospital, the computers that we use for electronic records, they are actually they're off. You can't surf the internet. They're completely isolated. So then
yeah.
there's a separate system
The
for our own computers.
firewalls and stuff, security reasons.
Oh yeah, no. Basically, you can't surf anymore. It's all shut down. It's all isolated. It's just for cyber security reasons. So you can't do any serving, and so the main broadbands are used for those stuff, and then the rest are just along the way, and it's shared with the public as well. So it's not so good.
Okay, very good. Now you met Vlad. Vlad, are you there?
Yeah, Doctor,
Yes.
I'm here. I'm listening.
Yeah, Vlad is a medical student. He's last year he's considering neurosurgery.
Oh,
Yeah,
wow.
nice to meet you all.
Mm-hmm.
Yeah, I was telling.
Good for you.
Well, I was telling Vlad, this is a great way to meet people like you. I mean, this is how things start. Networking.
Mm-hmm.
But when did you start? Romania is different than neurosurgery. It's what is it? A general surgery internship and then a residency? How does it work?
So there are 6 years of medical school in Romania.
You're the last year, right?
Yeah, we have adopted the French system. We go by them, meaning that after all those 6 years, we take an exam. We give an exam called the residency exam. After we take that exam, we can choose our specialty.
Oh, okay. And that's in medical school.
Yeah, we are sorted by our grade that we have took in the exam,
Okay, and a neurosurgery residency, how long is it in Romania?
A couple of years ago, it was 7 years, but now they reduced it to 1 year, and now it's 6 years.
6 years, okay. That's after internship, or that includes internship?
Actually, that's the quite funny thing. We don't have this idea of internship.
Yeah, like we do in this country, yeah.
Yeah, I know that different countries have internship. We don't have it. That's
okay.
the difference.
So for medical school, you go straight into neurosurgery?
Yeah, that's exactly. Yeah.
So you may not have a lot of experience dealing with general medical issues, even general surgical issues.
Yeah, that's right. But during our residency, we also take hours. For example, in the first year, we have hours of anesthesia, of emergency, or of general medicine. They are trying to
rotating.
Yeah, exactly, rotating. Yeah.
Okay, and you're exposed to the specialties that way.
Yeah. We're also working in a hospital, but we also learning those years.
Okay.
This is a difference.
Very good. Yeah. So a webcast like this, basically, you try to see that the sound's working okay, and of course, if there's any problems, any questions, and one thing that I find very hard sometimes is to keep it moving. Because as a host, I mean, you're responsible. You're responsible for keeping things flowing. Yeah. And sometimes it gets hard because you'll have a presentation and no one will ask any questions. And you're sitting there.
That's why you need a very good moderator, someone like Kate, who can, add on, make
they can
flow.
Well, that's why I like to have Warlicks, because she knows neurosurgery and she can tell the important questions. Someone like me can't. But she can, and Vlad.
You become good at it. You've had
you learn a little bit. You fudge. You try to get by, but I like to have someone like Vlad, someone that has an interest in neurosurgery. I'd like to have them as the main moderator.
Yeah,
but
if you need help, just shout. Okay, we'll find something to.
Yeah. Well, anytime you want to just hang out, we have a webcast. I could always use the co-host.
Yep, no problem.
Yeah. All you do is just sit there and let people in and watch it and stuff.
Yeah.
It's kind of nice, and it's kind of nice meeting people, from all over the place. Now that we're all, I imagine you don't. Do you stay around the hospital and you're home most of the time?
I don't know. This is night now. It's 9, close to 9:30 in the night now here.
Oh, okay.
So yeah, we're at home, but daytime, that's when
It's
you have the
usual
nighttime.
usual
Yeah,
routine.
usual, 8 to 6 hours in the hospital. Yeah.
Well, Miami Beach, the streets are empty. It's
It's
I
because
don't
of
know what
COVID.
it's Singapore. A lot of people in the street.
Yeah, the numbers are virtually back now. Of course, I think it's still around maybe 80%, because there are some people still working from home. The
Yeah.
government is encouraging, and if you don't need to go to the office, you don't need to. But I think for doctors, I mean, you have to go to the hospital where the patients are. But
Yeah.
our hospitals admin staff, half of them are at home, half of them are at work, and they rotate.
Oh, they're at home.
Yeah.
Yeah. Yeah. The world is changing.
Yep.
It's a good chance,
Hopefully,
really.
hopefully next year, we will travel again.
Yeah, well, I was really glad to hear about that vaccine yesterday, and I watched. I'm probably like you. I get sick of the news. I don't want to hear any more about you know. But I said,
Yeah.
well, I got to learn about what's going on with this vaccine, and after
The only
watching it,
thing the only thing you don't know is actually how long it works for. Is it a few weeks, a
yeah,
few months?
there's a lot of questions. Yeah, there's still a lot of
Yes.
questions, but it's a good sign. It's a
It's
good
a good,
sign.
yeah, and I think the science is good. So that's really the most important thing. That's why they could get it all out so fast.
Well, I don't know if the doctors in the United States, Anthony Fauci.
Yes,
He's
yes.
one of the biggest health guys. He was working with Trump. They had kind of an adversarial relationship towards the end
Yeah.
because, as you know, Mr. Trump is not a scientist. and he was at odds with Anthony. And Anthony, he is a great scientist. He's one of the guys that helped get HIV, the research behind HIV. He was very big in fighting HIV and leading our country out of that difficult time. I still remember those times. That was a difficult time in our country. I don't know, was it like that in Singapore too? It was pretty rough.
No. It's much
No, it wasn't.
quieter.
It was bad. It was bad in a couple of cities, San Francisco, New York, and
Yes,
it
I
was
remember
very
those
bad
times, yeah.
here in this country.
Yeah. So
And
time when I first started doing medicine, I think, just a short while after I started medicine.
Yeah, he led us out of that.
Right.
They eventually developed medication, the protease inhibitors. That was a big step. And I think they even have better drugs now. I haven't. I can remember walking in the emergency room and seeing pneumonia patients that were going to die. They knew they had AIDS. This is the early days of AIDS.
Right.
And they knew, well, they got pneumonia. They're going to die shortly. Every day in the emergency room, I'd come in, people would be, dying of HIV. At one point, it was bad.
Right. Yes.
But it was never that bad in Singapore, huh?
No, because the gay community was in those days a bit more quiet,
Yeah, yeah. It was a totally different time. It kind of reminded me of now, in a way, of looking for the drug, they finally identified the disease. They had a hard time identifying what was causing all these clinical, remember the first days, they didn't know what it was. And then they isolated the virus, the HIV virus, finally, and then they started working on getting medication. And that was quite a journey in history. So, okay. Hey, Vlad, we'll talk. Okay, thank you, Duane. Thanks for everything. It was excellent.
Thanks, John. Thanks for hosting this. It's amazing.
It's fun. It's fun. It's fun. We'll have. Don't worry. We'll have Warlick's back next week.
Yeah.
People complain. Okay.
Okay. You take care.
Okay.
And keep safe. Okay.
Bye-bye.
Thank you very much.